Vielleicht jetzt? Jetzt habe ich vielleicht Ton. Okay. Hopefully I have some sound. I'm sorry, I'm still struggling with the sound. And let's see if I have it. I have the live stream here. There's a slight delay. Okay. Yeah. Now I have sound. So once again, welcome to UroChannel. On this cold Friday evening where I am sitting in my room alone. No, maybe not. I have somebody telling me that I have sound, but it's November and it's the first day that it snows around here. So wherever you are, maybe you're watching me from a warmer place, it's very cold and unpleasant outside. But it's good to sit here in the warmth of a room and to do a YouTube live stream. First of all, I want to thank you very much, all of you, that you subscribed and liked my videos. I was asking you in the last 2 videos to do that because the YouTube algorithm is judging my content by the amount of likes and subscribes I get from it. So my channel won't grow that fast or that much if you wouldn't do that, and it doesn't cost you anything, but I'm very pleased that you are such fans of UroChannel and that you want to support me. So thank you very much for doing that. You know, it's like always in life, when people have negative thoughts about content, they are very easy to share that with everybody else and give thumbs down, write hate comments. I get lots of hate comments. You don't see them because I never let them through. But this also affects the YouTube algorithm. So if I get dislikes on my content, then the YouTube algorithm thinks it's not worth promoting. So I'm very pleased that you did give them thumbs up, and that the videos were that the YouTube algorithm liked the video, so they are promoted. Thanks a lot. What we want to do today is prostatitis. Prostatitis is a topic I've been dealing with for quite a while now. And this is something that comes up now and again. And even today I had a patient with pain. So now we don't really call it chronic prostatitis. Yes, there are some categories for that, but the overall term would be CPPS, which is chronic pelvic pain syndrome. And chronic prostatitis is one of those syndromes, together with bladder pain syndromes and all of that stuff. But prostatitis is a diagnosis that is easily applied to men with pelvic pain. I think it is applied too easy, because we have to differentiate where is the pain coming from, and many times you don't know. But if you look at prostatitis, there is really one very easy diagnosis, which is acute prostatitis. Acute bacterial prostatitis, that's the correct term. And that means that bacteria get inside the prostate and cause an inflammation and an infection that will soon take over the whole body. That means that if you get acute bacterial prostatitis, you feel very sick, really sick. So most probably you end up in hospital because of that. You get high fever, it's very painful, you have urgency, pain in the rectal area, prostatic area. You have to go to the bathroom constantly, both for defecation and for urination. And this is a dangerous situation, because you soon get into to a point where you get sepsis, which means blood poisoning, which is then life-threatening. So you really have to get antibiotics, and you have to get that treated quickly. This diagnosis is, I think it's quite easy, because you have a very defined term. You get the bacteria in the urine. It's kind of easy to diagnose. Then you have chronic bacterial prostatitis. Now here gets very difficult, because you have bacteria in the prostate, and you have to imagine that the prostate is a gland. It sits underneath the bladder, and it is composed of very many singular glands. All these make up the prostate. In these, it's a labyrinth kind of. So the bacteria that get inside the prostate, they like it there because they can hide and they can just accumulate in places and you don't get them. This now and then will be reactivated, and these bacteria will cause a bout of inflammation and not doing so well. So this could be associated with fever. It could look like an acute prostatitis, but if it comes all over again and then after a couple of weeks you get this again, then it's more like a chronic thing. So chronic means it has to be present over a longer period of time. These cases are then becoming difficult because sometimes I get patients who have been diagnosed with chronic bacterial prostatitis because bacteria have been found, but it's something that's fluent and fluently becomes non-bacterial prostatitis, which is the most, in my view, the most complex term and the most not well understood condition in men. Chronic non-bacterial prostatitis, where you say there is a prostatitis, but there are no bacteria involved. And here it's very difficult to diagnose it because what can you do? You can take a urine sample, you can do what we call the 2 or 3 glass test, which means that you urinate before and after prostate massage, and then you have the prostatic fluids in the urine. And if this is positive and the urine from the bladder is negative, then you know it's from the prostate, and then you can make your diagnosis. Or you can cultivate ejaculate, which is also something that is usually done. However, I think it's difficult to diagnose chronic bacterial prostatitis because you always get bacteria in the ejaculate or in the urine, which has something to do with the urethra being involved. The urethra is the tube that connects the bladder to the outer world. The first 1 or 2 centimeters of the urethra, when you take it from the penile tip, they are saturated, or there are bacteria living there. That's just normal. But the urethra is flattened, so it's not open all the time. It opens when you urinate, but otherwise it's flat. And there's a pressure exerting the walls of the urethra, which means that a flat urethra wouldn't allow bacteria to climb up all the way to the prostate because they have to climb up several centimeters, like it's this amount of space that they have to overcome, which is difficult. So therefore, usually they don't make it that far. But if you take a urine sample or if you take an ejaculate sample, then all of this has to travel the other way. So it comes from the bladder or from this region and goes out. And on the way out, it will then take with it bacteria which just live there, and then they will be cultivated. And you get the impression that there may be bacteria in the prostate, while these are only bacteria from this specific part. I am very hesitant to give this diagnosis in cases where I find different bacteria. So one day it's like Klebsiella, next day it's E. coli, and then the other day it's Proteus or Citrobacter or whatever. Then I'm getting very skeptical about this diagnosis, because if you just think about it, bacteria get into the prostate and they live there. So it's just one kind of bacteria. I would then think that if it's always Klebsiella or if it's always E. coli, then yeah, maybe that's a chance. And then you have to have some amounts of bacteria. So just a few bacteria wouldn't do. And here it becomes very difficult because many get diagnosed with chronic bacterial prostatitis because of these results. And I think one should be careful to do that, because there is also this non-bacterial prostatitis. And I don't really know what non-bacterial prostatitis is. So I learned all of this stuff when I was a resident. And very far into my specialization, I was convinced that, well, maybe this is the way it goes. But since the pandemic, I am very skeptical towards this term, because, as you may know from my videos, I use shock waves. I use low intensity shock waves. Primarily, I bought this machine for treating erectile dysfunction. But then after a few years, the company approached me and asked whether I had some experience with chronic pelvic pain and shock waves. And I said, no, I don't. So there were some patients where I would have liked to test whether shock waves could be effective in chronic pelvic pain, but they wouldn't let me because, you know, nobody wants to be first. So they were all afraid of something I couldn't really know what the effect was. But then the pandemic came along, and miraculously, after half a year, so summer 20, there was a huge wave of patients sweeping over my office, of patients who had pelvic pain. And one of the first patients who came to me was an old friend of mine. He was diagnosed with chronic non-bacterial prostatitis by his local urologist. Then he called me up and he was very much in pain. So he was desperate, and he was asking whether he could come. So I made him come to my office, and he was literally crying. So he couldn't sit on a chair because of this pain. He had to kneel down on the floor or lean against the wall. That was the only position comfortable enough for him to just bear the pain. Then I said to him, you have to be number one. And I treated him with shock waves, which was terribly painful for him. But I adjusted the machine so that he could bear it, but it was very painful. What I found out later was that I hit trigger points in his pelvic floor. Trigger points are tender spots in the musculature of muscle fibers that have hardened because they are very tense. You may know trigger points from your own experience. We always have these kinds of spots in our bodies. So the classic would be the neck musculature. When you get a massage and it really hurts, these are trigger points, and you can get those also within the pelvic floor. And what I did with my machine was I hit these trigger points and I made them go away. Took 6 weeks. After 6 weeks, he was totally pain-free. And that was the beginning of me becoming interested in the pelvic floor and questioning the concept of chronic non-bacterial prostatitis. So today, I'm not quite sure whether this is something that really exists. I then had a second wave of patients coming in the first month of 2021. And also in this wave, I had lots of success with shock waves. So in conclusion of my experiences, I think most of this is muscle. So pelvic floor, there are several layers of muscle which interact with each other. The pelvic floor has a lot of functions, so it has to be active in stabilizing the body. It's the middle of the body. It stabilizes the lower body against the upper body, and in the end of the day, it's a coordination for movement. The other thing is that the pelvic floor is active in like urination, defecation, and also in sexual activity. So you need it for different tasks performed in the body. But in order to do so, it has to be relaxed and it has to contract. And sometimes you give the pelvic floor too much to work with, so it reacts with contraction. Contraction can happen if you sit a lot, if there's something in your movement patterns, something in your sleep patterns, something in your psyche when you are having problems and you're trying inadvertently to compensate them, then you contract muscle. Some do this in the neck, some do this with the jaws, and some do this with the pelvic floor. In the end, you will never be sure what the reason for pelvic floor overactivity was. But the result is the same. So in pelvic floor overactivity, we get these pains like if it was some kind of prostatitis, because it feels in that area. You can't really tell, is it the prostate, is it the muscle, because it's also very packed in this area. So you would never be able to discriminate what exactly is it that's causing the pain. But tense muscle will also have an influence on, like, for example, nerves. So if you have something that compresses nerves, which then, for example, lead into the testicles, then you would get testicular pain. And this is nothing that's in the testicles, it's something that's higher up, it's on the pelvic floor. Same with bladder pain, but bladder pain is a little bit different. But also here you can get all kinds of symptoms, for example, frequent urination, urgency, funny feelings in your bladder. All of this can be linked to the pelvic floor. And then you are in the middle of something that's called CPPS, chronic pelvic pain syndrome. So chronic prostatitis, chronic non-bacterial prostatitis, is a very hard nut to crack. I was very lucky that with shockwaves I could solve some of these problems, but there are patients whom I couldn't help with that. So the question remains, in these pain patients, what's happening with them? Is it something that's in the bladder? There's a condition called interstitial cystitis, but we really don't know what exactly this is. You can kind of see it if you do a cystoscopy, and in patients who have long gone down the path with this disease, you can see that it starts to bleed. Once you fill up the bladder, you will see bleeding from the bladder wall, or you can see something that's called the Hanner's ulcus, which is a condition that you can see in the bladder wall. So it's not easy to diagnose. You should have seen some of these cases to have an idea, maybe this is something that's resembling interstitial cystitis. But in most patients, it will end up with the bladder shrinking. So what they tell you is that they have to go to the bathroom and they have low volumes of urine every time. But once they went to the bathroom, they have immediate relief. So they start to go to the bathroom very often. But then the bladder will start to shrink, and in the end, it will only hold a couple of milliliters. That's the most severe form, but this will take years, and men are usually not that much affected. It's mostly women. I think it's 2/3 women and 1/3 men. So it's mostly a disease that you can see in women. But even here, there are some reports about shock waves being helpful. I tried shock waves in a very advanced case. It didn't help. But as you have seen, if you have seen my video about urgency in a patient with multiple sclerosis this year, where I applied shock waves and EMTT, which is magnetic therapy, obviously there is something that we can bring about. So lots of research questions which open up here and that haven't been answered so far. That's very difficult to deal with these kind of issues, and this is why we're calling this CPPS. Let's have a drink from my cup. It's the rock hard cup. I really like this one. Okay, let's see if I see some of the chat messages. Oh, hello from a stress-free VIP from South Sea. Yes, I can imagine. It's very stressful. It's very warm up down there. Then somebody is yep, some medication. Okay, by the way, if you have personal health stories, I wouldn't answer to them because I must not do that. It's something that's against the law in my country. I must not answer to any personal questions on personal health stuff. So I'm just informing generally on medical topics and medical issues. But while I was talking about EMTT, I wanted to refer to my latest video, which I uploaded on Wednesday. It was about EMTT, which is extracorporeal magnetotransduction therapy. This is a very new treatment form that has been around for 4 years now. Not many people use it, and it has so far been used primarily for musculoskeletal disease. Orthopedics use it a lot, if they use it, but they are fascinated about it. And in the bigger town here, which is close to Göttingen, it's about 150 kilometers Hannover. There was one colleague, he's doing lots of this and he's publishing lots of his reports and his findings about EMTT, and it's very fascinating. As I report in my video about EMTT, I had a friend here 2 weeks ago. He was in pain because his back went out of him, on him. And then I thought, okay, I'm a urologist, but I have this machine and it works in orthopedics. So maybe it works with him as well. So I called him up and told him to come, which he did. And it was very difficult for him to walk because of the pain. And he could barely sit down, but I made him sit down. And then I applied these magnetic waves. It's kind of like shock waves, so it's the same frequency. It's 8 pulses per second that I can set the machine to. And it sounds almost like shock waves, but it's not. It's magnetic impulses. And when I was done, he got up and he showed me his leg. So he could move his leg much better than when he came to my office. And he walked much faster back to his car, as a matter of fact. That was very encouraging. So I told him, come back next day and I will see how it looks like, and then we do another session. And the next day, it was like a miracle cure. He came to my office, he could drive himself, his wife didn't have to take him, and he told me that the pain was still there slightly, but it was no comparison to the day before, and it felt more like a sore muscle and nothing else. So I treated him once again, and then issue was resolved. I think this was very impressive because some patients get very skeptical about the EMTT because they don't feel anything. It's completely painless. But if you apply it to certain spots in your body where you have some problems, like I had some problems with my shoulders, and if you have some inflammation going on, you put it near the shoulders, it really hurts. It's a very yucky feeling. It's not a real, it's a very unpleasant kind of pain, I can say. It's not nothing that you want to have all day, but you can bear it for 10, 20 minutes. That's no problem. It's not very, very severe, but it's kind of yucky. But on the penis and the pelvic floor, so far I've never seen a patient who felt anything about that. EMTT is kind of similar to these pelvic chairs. You might know them. You sit in them and then you switch on the magnetic field and you really can feel it in your pelvic floor muscles. These devices are called PEMF, which is pulsed electromagnetic fields. That's the name of it. And these are much weaker than EMTT. EMTT is 8 times the strength of PEMF, and it's much faster. So the impulses it can generate, it generates one impulse every 7 microseconds, and PEMF does this every 280 microseconds. So it's much faster, and the energy that's transduced into the tissues is much higher. Maybe this is something that has a future in medicine. We don't have data on this for male sexual health. and that's how it is. We have data on male sexual health for PMF and other forms of magnetism. So magnetism itself, it's nothing new, right? So in old Egypt, they have been using magnets, or in China, and magnets have accompanied medicine from the very old ages, from the antiques until today. But now we're using magnetism in totally different ways. But we have had this idea that magnets have some kind of healing power. Question is, how much energy do we need to achieve that? And PMF has shown results, but the results were not uniform. So sometimes it showed results, sometimes it didn't. Maybe PEMF is just on the verge of healing and doing this to some patients, but maybe it's not powerful enough to have large impacts. So I'm very interested in seeing what happens with EMTT. But knowing that PEMF is effective indeed for the pelvic floor, for example. So these chairs, they work on the pelvic floor. I'm pretty sure it has an effect. And this year I am combining EMTT with ESWT, which is shock waves, and also the P-shot, which is PRP, platelet-rich plasma. And I've seen some results which were remarkable. So we'll continue with this approach next year and collect some more data. And then I will tell you what I found. But so far, it looks very promising. So let's see if we have another chat message. No. Yeah, Jamie is asking about prostate abdominal flank pain. Not quite sure what you mean by that, because prostatic pain is usually felt in the perineum, which is the area between the legs, and not in the flank. So would be the kidneys, but very often the kidneys only cause pain if there is a stone involved. What's a big problem here in this area is, again, muscle. It's about the spinal cord, herniation of discs maybe, or some overactivity in some muscles of the trunk. So this also gives pain. I've seen this a lot, and people come to my office with pain in the kidney areas, and they think there's something wrong with the kidneys, but it's muscle in reality. So this is not urology, it's kind of muscle. But I'm interested in muscle because, as you may know, I'm also specialized into sports medicine, and super specialized into golf medicine. So I did this certification at the TPI, the Titleist Performance Institute. And I learned a lot of this by doing this, because they have a totally different approach than we have here in Germany, what I have learned. So they look at the human body in terms of movement patterns, and they look for dysfunction, identifying dysfunctional movement patterns, which I think is very interesting and very fascinating, because it explains a lot of things that I've been struggling with in urology, because suddenly I think we have to look more at muscle. And this brings me back to the pelvic floor and to chronic prostatitis. I know that many want to activate their pelvic floor and to train their pelvic floor, but I'm very critical, because first you have to know how to activate the pelvic floor. I think this is crucial, because we know from research that about 25 to 30% of all the people, men and women, they don't know how to activate the pelvic floor. I had a patient yesterday, and when I examine patients, I always do a rectal exam, because then I have the opportunity to assess the sphincter tone, to assess the pelvic floor muscle tone, and at the same time identify any tender spots or trigger points which may be in this area. And I asked the patient to contract his pelvic floor, and he couldn't do it. It was impossible. And his pelvic floor tone was fine, his sphincter tone was fine. So he didn't have any underactivity or a weak pelvic floor. He didn't have an overactive or compressed pelvic floor. It was just that he couldn't contract his pelvic floor. And if you can't contract the pelvic floor, it's hard to do pelvic floor training, I think, because you have to know what you're doing. It's the same. Now we're talking golf medicine. It's the same. If you don't know how to activate your glutes, which is the king of the golf swing. So the glute is the most important muscle in the golf swing. If you don't know, if you want to train that and you don't know how to activate it, then you can't train it. It's as simple as that. And it's the same with the pelvic floor. So you have to know how to activate it to be able to do some pelvic floor training. This is one problem. The other problem is that if you can activate it and if you train it, there's a chance that if you overdo it, which many men do, they have a tendency to overdo it, then you may get an overactive pelvic floor, which is not good for what you want to achieve. And usually it's erections. For erections, you need a functional pelvic floor, which is not the same as a tight or a strong pelvic floor. A functional pelvic floor is strong, but it knows to relax. An overactive pelvic floor is too strong and it doesn't know how to relax. And this leads to the muscles not doing their job, which then leads to erectile dysfunction. I have many patients where I see erectile dysfunction because of a tight and overactive pelvic floor. Which brings me back to ESWT and the pandemic for my pelvic floor pain patients. This was one of the findings I had with my patient, one of my patients, when he was telling me that since I started ESWT on him, the shockwave therapy, and he loosened up, he suddenly started to get nighttime erections again, which he didn't have. And we didn't talk about this beforehand. That was totally new to him. So I asked all my pain patients about their erections, and turns out many of them have slight erectile problems, which then got better once I treated the trigger points or the overactive pelvic floor. So this was my conclusion, that pelvic floor overactivity is not good for erections. So if you want to do anything good for your erections by training, I think if you want to activate the pelvic floor, you have to have an assessment first. So somebody who is trained to access the pelvic floor to find out whether you are able to contract your pelvic floor, and next, whether you need pelvic floor training or whether you need functional training where you learn how to relax and contract your pelvic floor and not just contract your pelvic floor. I think this will help you the most in these cases. You can't do that yourself, by the way. So you have to have some kind of physiotherapist. They're usually physiotherapists who are good at this, but they have to have a specialty in the pelvic floor. Otherwise, I'm quite skeptical they would be able to assess the pelvic floor properly. Okay, let's see if we have some more questions or... Yeah, it's infrared light treatment. A colleague is writing that he has some experiences that it's possible. I mean, there are lots of ways of how to deal with that. Acupressure can be something that maybe can help. And I know that there are pelvic floor physiotherapists who do, I don't know if it's prostate massage, but they do rectal pelvic floor pressure point activation. They are not allowed to do this in Germany, but I think in other countries they do that. That would be kind of similar to ESWT, where you direct the power onto these pressure points. And infrared light also gives some heat. So warmth is also beneficial. Many patients will tell me that if they apply some kind of warmth, then the pain will lessen somewhat. So I think it's possible that infrared light may have some effects in this area. Somebody has Tamsulosin. Yes, Tamsulosin is for pelvic pain, for chronic prostatitis, is something that I also prescribe, but it's more for diagnostic purposes. I would say it's 70% diagnosis and 30% treatment. There are a special subset of patients which have very good effect of Tamsulosin. Tamsulosin is an alpha blocker, which is selective, which means that it relaxes the muscles around the bladder neck. In pelvic floor issues, sometimes, that's my thinking, the muscles around the bladder neck are also hyperactive, which can lead to some sorts of lower urinary tract symptoms, where you get urgency out of the blue, and then you went to the bathroom and now you have to go again and nothing's coming out, for example. And in these patients, Tamsulosin works in around, I would say, 20 to 30% of patients. So if it works, it goes like this. It's on the same day. You take this tablet in the morning, and in the afternoon you're completely pain-free, and you feel very relieved from all your troubles. This is how it works, if it works. And I tell my patients, take it 3 days. If it's not working after 3 days, and if you have to think whether it works or not, then it's not working, and then you can just leave it, because it won't have any effect on you. This is how I'm using it. If it works, I let them stay onto the Tamsulosin for a period where I then initiate shockwave therapy, and usually then they can just skip it and they will be fine. So this is something that has been shown to work. So I think if we talk about shock waves, the most spectacular effects I've seen is not with erectile dysfunction. It has been with pelvic pain. In some patients, it's really effective. But I'm talking about real shock waves. I have to say that because I know that many of you are watching from the US. Shockwave therapy doesn't have the approval the same way it does have in Europe. So what you will most probably receive in the US is a pressure wave therapy, which is not shockwave. It's marketed under the same label, but shock waves are special forms of acoustic waves that are brought about by electromagnetic stimulation of something, then piezoelectric and electrohydraulic. These are the methods to bring about shock waves. A shock wave travels through a given matter faster than sound would ideally. So it's very fast, and it really stresses the cells, and then you even get a negative pressure because the cells get compressed and then they expand after the wave just swept over them. It's not the same with radial pressure waves because they behave differently. These are generated in a cylinder where air is compressed by a projectile. You just shoot a projectile, and then a burst of air comes out. These are also acoustic waves, but they behave differently. So they stay more on the outer layers. They are not focused, and they are used and useful in certain orthopedic disorders. But so far, we don't really have data for them being effective in this area what I'm talking about. So maybe they are effective. I wouldn't be able to say because I'm not using them. I've used shock waves all of my professional life, but I think they're effective, but I'm not just sure whether they are effective for this special kind of indication. Okay, Brandon Ross says, I love your channel. Thank you very much. Thank you for your support. That it feels good because I read a lot of comments, and some of them are really not nice. So it's good to hear something nice once in a while. Tomorrow's video, is going to be a very special one, and it was triggered by one of my TikTok videos that I did. I did a TikTok this week in German about spontaneous nighttime erections in men, but I have a lot of female viewers on TikTok for some reason, and they were writing me, what about women? So I made a video about nighttime erections in women. So this is tomorrow's video. I would like to thank you for being there, for listening to me. And as you know, every Friday, 8 o'clock Central European time, I will do a live stream. I'm not quite sure what I'm going to do next week, but I will find out during the next days to come. I wish you a nice weekend. And wherever you are, maybe you're in the morning, or if it's in the evening, then have a nice evening or have a nice day. See you soon. Bye-bye.